Hi, everybody. My name is Caroline Verheijen. I live in Belgium and have recently joined ELF's sarcoidosis patient advisory group as a patient representative. I would like to warmly welcome you to today's webinar. We really appreciate you taking the time to join with us today, and we hope you will find it useful. The program for today's webinar is now on screen. We will try to keep to time and finish at 4 p.m. So just a few housekeeping points to begin with. Please note that all participants are on mute with no videos showing. Please do not unmute yourself. And if you encounter any technical difficulties, please email info@europeanlung.org and ELF staff will help you. Do feel free to say hello in the chat box and tell us where you are from. You also have the chance to write any questions you may have in the Q&A box. Okay, so, but who or what is ELF? ELF is the European Lung Foundation, an organization which aims to connect patients with healthcare professionals to strengthen the cooperation between the two and improve the care of the patient. ELF gives a voice to any patient with a lung condition, whether you have asthma, CF, or sarcoidosis. The Sarcoidosis Patient Advisory Group is a group of patient advocates from across the world that have been working together since 2015. They are involved in a range of projects to raise awareness and improve treatment and care for people with sarcoidosis. You can see some of the things they have been involved in on the site, and you can find out more about work they have been doing at www.europeanlunginfo.org/sarcoidosis. Yes, today we are going to listen to Professor Baughman, who specializes in sarcoidosis from Cincinnati University, USA, and he will talk to us about the latest European sarcoidosis treatment recommendations. You will have the chance to post your questions around sarcoidosis, which will be answered by Professor Baughman after his presentation. You can write your questions in the Q&A box at any time during the webinar. After the presentation, we are going to watch a short video on the treatment guidelines of sarcoidosis. So, Professor Baughman, are you ready to take the floor? Do you have your glass of water ready? Then we can listen to you and think about what we would like to ask you around sarcoidosis.
Thank you very much for the nice introduction, Caroline. And again, want to thank the European Lung Foundation for their efforts in this effort. This is the European Respiratory Society guidelines. I want to talk about that. Next slide, please. This was a task force that developed about 6 years ago now. You can see quite a few members of the task force, and I'll be giving their names later, but including 2 people that were specifically from the ELF. Next slide. Now, guideline developments are a very specific process nowadays in medicine. And you start off by formulating a question. You look at particular outcomes that you want to look at. For example, what can improve survival or quality of life in a disease such as sarcoidosis. And then you go forward with a systematic review of what's in the literature. And then you develop what's called a grade recommendation, which I'll discuss in detail because this is a very specific recommendation. You can have a bunch of people sitting around a table and make a recommendation, and that is not as precise as we'd like to see. In the last few years, you've heard recommendations made, for example, about COVID, which get hacked later on. But when you have data, the better the recommendations. And in medicine, we use this grade process to try to get a sense of how solid the information is. This is important because as we move forward, you're looking at the evidence for the that supports a recommendation can be made. And we can grade this recommendation so that it can be useful in your healthcare provider to make decisions about your care for you and them. Next slide. So these were the topics that we ended up looking at. We looked at things such as pulmonary sarcoidosis and looking at corticosteroid therapy like prednisone and prednisolone, and then extrapulmonary manifestations like skin manifestations, heart, brain. We looked also specifically at fatigue and their small fiber neuropathy. And we broke it down between steroids and non-steroid therapy in a couple cases, specifically in the lungs, where there was enough information to talk about both of those issues. And you can see not only the clinicians involved, but methodologists, that is the people that help do the statistical analysis, and then finally the patient representatives from across Europe and the US. Next slide. So what is the grade format? This is not something specific for these recommendations. This has been standardly applied for many years now. And recommendations can be can be either strong, or they can be conditional, or they can be need more data. And the evidence that could support it can be moderate or high or low. So there's two parts of it. There can be the recommendation and the certainty of the evidence. Next slide. So when we show these panels, and I'll show one of these in detail in just a few minutes, we provided a key on the lower left column. So when you're looking at these recommendations, you can see that their recommendations can be strong or they can be conditional. And I'll explain those two in just a second. But they can also have levels of evidence. They can be low or very low, or they can be moderate, or they can be high. Unfortunately, there are not enough clinical trials done in sarcoidosis that are placebo-controlled, that is with people not getting a particular type of therapy, so that we often are left with low quality of evidence. This does not prevent us from making strong recommendations when we felt it was necessary. We also saw things that we currently do in practice by most of the people on the committee, but did not have support of enough evidence to support, and they became called current practice. And then there were also situations where an intervention, usually a new intervention, has been introduced, and it was used by many of the centers, but on a case-by-case basis, meaning not based on what would happen in the person in the past or what the next treatment would be. And so these were a guideline to what to do. Next slide. So what is a strong recommendation? Well, strong recommendation, again, follows standardized terminology. This has been set up by the McMaster group and the Cochrane group. And in a strong recommendation, most people in this situation would follow this recommended course of action. A clinician or a healthcare provider would recommend that the patient receive this recommendation, and that policymakers, insurance companies, for example, would be supported in giving this recommendation so that they would provide funding for it if it's necessary for the patient. So let's take an example of a strong recommendation. Next slide. So a strong recommendation is to not add rat poison to your cereal. Now, I have to tell you, there is no randomized trial showing that people who did not take rat poisoning did better than those that took rat poisoning in their cereal. But this is still a strong recommendation: do not put poison in your cereal. So next slide. An implications of a conditional or weak recommendation is that the majority of people in this situation would want the recommendation, but not always. And the clinicians may be prepared to help the patient make a decision about this, looking at the risks and benefits of a particular course of action. And this is often where you're talking about the benefits versus the possible potential side effects and cost. Policymakers should be supportive of this decision. And if the debate could be going, they may say, well, there's another equally course of action, that's fine. But if there isn't, they should be supportive if that conditional recommendation is made. Next slide. So conditional recommendations: do not add expired milk to your cereal. Now this, you can think about examples of where expired milk may still be something you would consider, doesn't smell bad, looks okay, and that sometimes the expiration date is put on arbitrarily. But in general, we recommend that you don't take expired milk on your cereal. Next slide. So how does this fit into the ERS guidelines? Well, overall, there are really only two reasons to treat patients with sarcoidosis. One is to prevent danger, which is death or organ failure, and the other is to improve quality of life. And these are the two general categories that as a healthcare provider, when we look at a patient, we have to decide what can we do to help the patient. And this is what drove our recommendations in some cases. Next slide. So particularly looking at pulmonary lung sarcoidosis, there were three general categories of patients that we saw. About a third of patients with sarcoid we considered at low risk, meaning that they really didn't have any risk for developing end organ failure. They also had no real risk for impaired quality of life. They were feeling good. They were picked up, say, incidentally on a chest x-ray. And in that situation, the recommendation to the committee was to observe. However, if the patient started developing symptoms and became more severe, then the strong recommendation of the committee was that they be placed on glucocorticoid therapy. And this was actually the low level of evidence. It was a strong recommendation. Again, this represents about a third of patients with pulmonary sarcoidosis. Next slide. The group with the most data was the group at high risk. That's because most studies were designed on patients who were felt to be at risk for developing end organ failure or even death. And the first recommendation is give glucocorticoids. This was a strong recommendation, even though the evidence was very low. And the committee felt strongly that patients with symptomatic, that is short of breath or cough or severe chest pain related to the pulmonary sarcoidosis should be given a trial of glucocorticoids. The important thing the committee felt was that it should be evaluated on a regular basis whether the symptoms were responding and if the patient was able to get down on their dose of steroids. If they couldn't get down on their dose of steroids, then alternative drugs should be considered. And the next class of drugs were considered the cytotoxic or antimetabolites. And the only one with a conditional recommendation was methotrexate. And that's because there have been trials looking at this with sufficient evidence supporting methotrexate. There are other drugs that have been used, including azathioprine and leflunomide and mycophenolate, that are commonly used by different centers based on their experience and their comfort level and the patient's own profile of what drugs they could tolerate. But the evidence that is most supportive is methotrexate. The committee did not feel that these other drugs were any worse or better than methotrexate. It was just that the evidence was more supportive of methotrexate. Again, if the patient could not be tapered down on steroids, and about half the time steroid sparing can be achieved with methotrexate, then the next level of drug was infliximab or dilimab. And here the committee again gave a conditional recommendation, but the evidence was actually better than that seen with methotrexate and similar, if not better than that seen with glucocorticoids. So here's an example of a recommendation that's conditional because of not everyone felt that every patient should be given infliximab, for example, but the evidence was fairly good that if the patient was a candidate for infliximab, that drug should be used. Unfortunately, not everyone can tolerate infliximab or dilimab. Not every insurance company will pay for it, for example, and then alternative drugs had to be considered. In our situation, over the years, about half the patients started on infliximab have to look for another drug, and the drugs that have been used that the committee felt were worth considering included rituximab, JAK2 inhibitors, and repository corticotrope injection, or RCI, which is only available in the United States. Next slide. So if in general, quality of life is important, but only about 5 to 10% of patients actually die from sarcoidosis. So quality of life is actually more important for most patients with sarcoidosis. This is a survey done by the ELF several years ago while the committee was ongoing. And we asked over 1,800 patients, and the most important thing, the farther left, the more important. So quality of life and functionality were more important, for example, than survival. And for pulmonologists, this always hurts that the least important thing to the patient was their pulmonary function test, which if you've seen a pulmonologist, you know that PFTs are really more important than anything else. And most patients were willing to accept adverse events risk and even possibly changes in survival if it was going to improve their quality of life. Next slide. With this in mind, the committee then took out, therefore, this center group that patients with impaired quality of life should be treated. Now, it's important to note that there are no conditional or strong recommendations here because there have been no studies looking at this specifically group. But the recommendations follow the same recommendations that have been looked at for the high-risk patients. And we felt this was appropriate, that the patients at the intermediate risk but impaired quality of life should be considered. But it should be kept in mind that if the treatment made their quality of life worse, for example, high-dose steroids have more side effects sometimes than the actual disease, then you should move on to another treatment. Next slide. So using this guideline, the ERS not only developed recommendations specifically for lung disease, but they also did for skin, for heart, neurologic disease, sarcoid-associated fatigue, and sarcoid-associated small fiber neuropathy. Now, these guidelines have been published in the official journal of the European Respiratory Society, but the algorithm, the pictures that I just showed you with the flowcharts, are available through the ELF website. And I think that you should consider them yourself and talk with your healthcare provider if you're running into a problem about where to go next. These guidelines, we feel, are very important to give a roadmap of where to go. Next slide. So we have developed these guidelines with all this effort for various reasons. One is to help with healthcare providers, the other is to help with policymakers. These guidelines and recommendations are available, and comments regarding other specific therapies have been made. And we feel that in the long run that these are going to help in the management of sarcoidosis patients, but in part, this requires your help as well, because to implement these guidelines, you need to be aware of them and to talk with your healthcare provider about using them in particular situations. Next slide. Thank you very much. And now we're going to open this up to the next phase, which is a patient video, I believe.
Yes, thank you, Professor Baughman, for your excellent explanation. As I said, you can definitely ask questions in the chat box now, but first we are going to watch a small video about treatment guidelines of sarcoidosis. These guidelines were developed by patient representatives Gianluca Ziosi from Italy and Bernd Quadder from Germany, as well as healthcare professionals. The video shows the importance of patient involvement in guideline development. So we're going to watch that now. Thanks.
Hey, sorry, just putting the video on. For some reason, it's not showing on my screen share, so I'm just sorting the technical difficulties out. Bear with me.
While we're waiting for the video, I would encourage you to start writing your questions either in the chat box or in the question Q&A.
Sorry about that. I'll press play now.
Of course, to bring into the working group our patient experiences and also the different experiences of the patients and caregivers from different countries, because also the different national healthcare systems do have an impact on the problems and available treatment options, and of course on the reimbursement schemes. We could strongly promote that also general symptoms which have not really a good treatment option, like fatigue or small fiber neuropathy, could be taken into account to look for answers in the new guideline. So we were very thankful that also in the new guidance, it is expressed in the text where to go for future research and what is needed there. This was also a good experience to see the confidential collaboration between different associations and different patient advocates. and also with the medical associations and the sarcoidosis experts from Europe and US. We are hoping for easy to understand by the doctors, of course. The general practitioners, the pulmonologists throughout the world know these new guidelines, and hope that also the patient seminar now we're working for can give this as a tool to the patient, this new guideline, to go with it for his doctor and to ask for maybe treatment recheck, and maybe some new ideas can be used for the individual treatment of sarcoidosis patients through the world. And therefore, that's what we hope and promote, that also the patients should use the patient-friendly version published on the European Lung Foundation's website.
La partecipazione dell'Associazione dei pazienti alla task force per la definizione delle linee guida è fondamentale. Questo perché le associazioni possono portare le priorità dei pazienti per meglio orientare la definizione delle linee guida stesse. Partecipare alla task force sulle linee guida per la sarcoidosi ci ha consentito di poter porre l'accento su un elemento molto importante, che è la qualità della vita dei pazienti stessi. La comunità di lavoro tra medici e pazienti è all'interno delle task force ulteriore garanzia di possibili sviluppi futuri laddove queste linee guida siano mancanti in alcuni aspetti, e quindi poter garantire una continuità di sviluppo. Le attività di advocacy delle associazioni spesso e volentieri sono loro stesse un elemento che sollecita la definizione delle task force, come è successo nel caso della task force per la sarcoidosi. Per le associazioni è molto rilevante poter partecipare a queste task force, perché questo vuol dire poter disseminare le informazioni, quando questo ovviamente è consentito, verso i propri pazienti e i medici curanti. Grazie.
Okay, thank you. Okay, over now to the questions. We already have actually two questions. Let me just check how I can read this now. Okay, there is a question from Pauline. Can you speak about all over body and scalp itch with sarcoid? Is it associated with sarcoid or not? Consultant opinions vary. That is the first question.
Yeah, it's important to kind of separate this. First of all, sarcoidosis does affect the skin, and then the ELF has some guidelines about skin manifestations. But actually, sarcoid rashes often do not itch. It's one of the differentiating features. They can be pruritic, causing itching and stuff like that, but often they are not. When I have a patient who's itching all over, I wonder about whether they have a problem with their liver. Since if your liver can be affected with sarcoidosis, if severely affected enough, you can be itching just as a result of that. And that can be picked up by some blood tests of the liver function, a thing called bile acids buildup, in which case treatment for absorb the bile acids can help that. So it is something that you need to talk about with your primary physician. If they're not satisfied, which sounds like in the case, you might want to see a dermatologist since they often deal with itching. I see a question regarding the presence of sarcoidosis and incidence of joint arthritis. Myalgias and arthralgias are fairly common with sarcoidosis. Somewhere around 40 to 70% of patients will complain of joint stiffness and soreness. Direct joint involvement is relatively rare with sarcoidosis, only about 5% where you actually get swollen joints from the disease, but the myalgias and aches are common. And this is different than what we're talking about with small fiber neuropathy. It's truly a muscle stiffness and soreness. And there may not be any evidence of granulomatous disease, but it's actually there. It's just kind of like when you get the flu, you feel stiff and achy, and it's part of the inflammation. Larice Franca from Rio de Janeiro talked about the fact that she was diagnosed about 2 months ago after 10 months of investigation. And this is kind of a not uncommon situation where patients will have symptoms for months to sometimes even years, seeing 4 to 6 physicians before they finally make a diagnosis. And this is not uncommon with sarcoidosis. I think that we tend to start the clock at the time of the diagnosis. So you would still be considered a, quote, acute case. As far as finding a physician that will help you with this, there are some people in Sao Paulo that are interested in sarcoidosis. There are a couple of sarcoid clinics there. Carlos Pereira in Sao Paulo has, for example, done some work, and I've talked in Brazil and to the Brazilian Thoracic Society. So there are people within the Brazilian Thoracic Society. You might want to try to see if you can get some information from there. I don't know any specifically in Rio de Janeiro, but that would be where I would start with. And I think that's in general with the countries that you're at. You should think about contacting your ELF counterparts or the Thoracic Society. The next one is that the person who's had sarcoidosis from over the years has developed scarring in their lungs. This is an interesting point of sarcoidosis. If you talk about inflammation and scarring, so think about a rash on your skin. If it's red and inflamed, that's still inflamed. But if it just becomes scar tissue, most of our treatments are developed like prednisone for inflammation, but they will not have scar tissue. I have completed recently a study of one of the drugs that was developed specifically just to reverse scar tissue called pirfenidone. There's another one called nintedanib. These are used for other forms of lung fibrosis. Fortunately, progressive fibrosis and sarcoidosis is relatively rare. Only about 5 to 10% of people with sarcoid will develop that. But unfortunately for those people, once you get rid of the inflammation, we're still working on what would be the best step. Drugs like nintedanib and pirfenidone may help prevent further scarring, but we always want to be sure the inflammation is under control. You're taking prednisone 5 milligrams a day. The question is, do you have still ongoing inflammation? So in the task force, we specifically addressed doing other testing to see if there's ongoing inflammation and whether you should move on to drugs like methotrexate or infliximab. The one we most commonly use there is a PET scan. One of the questions is, what about the PET scan? How important it is? We use the PET scan nowadays in sarcoidosis. One, sometimes it's helpful in looking for an organ to biopsy, so part of the diagnosis, but most of the time we use it to determine whether more treatment should be given. Does somebody we're looking at have more ongoing inflammation? Getting back to the example of the skin, you can look at it and say, it's still red, I still have something to do, or if it's all scar tissue, but you can't do that in the lungs. You're just looking at shadows, and you can't tell whether there's still inflammation, and that's where we think the PET scan could be helpful. As far as cough, you've had a cough for 3 years, and now they're recently diagnosed for sarcoidosis. Cough is something that gets into this quality of life versus danger, and I think that cough can be an important part of it, of quality of life, and so therefore you should be thinking about if it's bad enough to take therapy. Corticosteroids can be quite helpful. Inhaled steroids occasionally can help. So, but you probably, if you've had cough for 3 years, you've been told multiple times it's probably asthma and been placed on multiple inhalers. And if you've taken a steroid inhaler and it doesn't work, that doesn't mean that prednisone may not help. And if prednisone helps and the side effects are too severe, then again, you go down that pathway of drugs like methotrexate or even occasionally infliximab.
Sorry,
one of the
Professor
questions is an important one, which is if I'm low risk at diagnosis, what is the likelihood that this can become high risk? Well, most of the information we have there is actually whether it's the likelihood of a new organ appearing. So if you have something, I tend to think in the first 6 months of someone is really kind of determine what's going to happen in the future. If they need treatment in the first 6 months, then they have a 50% chance down the road that they're going to continue to need treatment. However, if they don't need treatment in the first 6 months, after diagnosis, not prior to diagnosis, but at time of diagnosis, if they aren't sick enough to need treatment, then their chances of down the road needing to be on treatment are only about 10%. This has been shown in several studies. So I think the likelihood is less. We still think the patient should be followed carefully, especially for the first year or two, that is every 3 to 6 months, but after that, maybe once every 6 months to a year. The one exception is cardiac disease. And if you have symptoms for cardiac disease, then you should probably be seen regardless of how long ago your diagnosis can be. Overall, though, only about 5% of patients with sarcoid will develop cardiac involvement. There's a question about the calcium in the urine. This is about 10% of patients with sarcoidosis have too much calcium. And this is on the basis of actually usually of increased vitamin D 125. This is one of those complicated things in sarcoidosis. Patients who get vitamin D can actually have too much vitamin D on board. Not the one that your doctor normally measures, that's called the vitamin D25, but the body converts that to 125, and that's what we call the active form, the one that does all the work. Well, that conversion can be taking place in the granulomas at a much higher rate than normal. And that can lead to kidney failure, too high a calcium, or kidney stones if there's too much calcium in the urine. If that's the case, then you should be treating this with an anti-inflammatory regimen. Actually, hydroxychloroquine, or what are called antimalarials, sometimes can be all you need to take, and they have very low risk and very few side effects at the usual doses we use for sarcoidosis, and that may be all that's necessary. Most important thing to do, though, is to stop taking vitamin D supplements if you're in that situation. Your doctor should check your vitamin D 125 level to be sure that it isn't high. If it is high and you're on supplements and just simply stopping them may be all you need to do. We find that about 20% of the time. I would say that you should also check the parathyroid level, PTH, because occasionally it's not the sarcoidosis, but it's hyperparathyroidism, another rare condition. But that simply all can be checked by a blood test. So we get a vitamin D25, a vitamin D125, and a PTH level. That's the recommendations for evaluation of calcium. One of the questions that comes up is, how long does it generally take for sarcoid to melt away? Well, as I think I've made it clear, not everybody goes the same pathway. So going back to that example I told you, somebody who presents, about a third of the time they have no symptoms and they kind of do okay. And only about 10% of those people ever get on to need therapy. And after a few years, we can start talking about every year seeing them. But by about 5 years, we would tell that person what symptoms to watch for, palpitations, other symptoms that may come up, and let the doctors know that could be the sarcoidosis. But simply we say that it's in remission. I never tell people they're cured of the disease because we don't have a cure. We didn't do anything to intervene, but it simply can go not give any further problems. Patients who require therapy, about half those patients will continue to need treatment beyond 2 to 5 years. And of those patients who continue to need treatment, about 10% per year finally no longer need any therapy. And when therapy is withdrawn, the disease does not come back. So you can see that there's a group of patients that have acute disease that goes away, patients who have disease that will go away within a few years, and then there's those chronic patients that will continue on. So that's why I can't say that your disease will ever melt away. We do find that most patients, it does go away and become asymptomatic over time, but you never know that for sure. I don't think that you can ever tell somebody honestly that they will always need treatment, just like I can never tell somebody that they will never need treatment. You have to do it on an individual person by person basis.
Professor Baughman, there is a question here in the chat box. Can sarcoidosis cause spine pain or sinus drip and congestion?
Okay, these are two separate things. The spine pain, as I mentioned before, sarcoid can directly affect the joints. And what it does in the joints and in the bone is that the granulomas, the lumps, start to grow. Interestingly enough, about half the time when they're in the bones, they don't cause any symptoms at all. So I will see patients who come to me because they had an x-ray of their back and an MRI because they have low back pain from playing too much tennis or something. And they have a lesion there, which the doctors thought was cancer. They did a biopsy and they found sarcoidosis. Patients sent to me because they have no symptoms, but they were found to have a granuloma. So half the time they have no symptoms. The other half will chronically have symptoms. And in those patients, the treatment can be to try to suppress the inflammation, shrink the granulomas, and it can last for a long time. Now, you can also have back pain because of the myalgias and arthralgias I mentioned before. As far as sinus congestion, well, sarcoid can directly affect the sinuses. You can sometimes see this just looking at the sinuses, but the best test there is imaging, usually a CT scan or an MRI, look at the sinuses. And sometimes the treatment with just topical steroids will help.
There's another question in the chat box. Also, any magical hints in dealing with the associated fatigue?
Okay, and the fatigue specifically, the task force made specific recommendations because there have been a couple well-done studies showing treatment options for this. One option is physical therapy, and actually it doesn't have to be specific types of pulmonary rehab or such like that. The studies looked at 2 different types of rehabilitation, and it found that in general, exercise on a regular basis did help reduce fatigue. This is generally recommended. The other were 2 studies done by our group looking at drugs that are called neurostimulants. These are drugs like methylphenidate in the United States called Ritalin, and another drug called Provigil or modafinil. And these are drugs that are used to things for ADHD. They are things that will help with fatigue. People with sleep apnea keep falling asleep. And we showed in crossover trials that they were very helpful reducing fatigue and sarcoidosis. The problem with the drugs is that they only work for the time that you take them. They work for about 8-12 hours, and then they wear off, and you have to take it again the next day. But I think that what we recommended is to recognize that fatigue is common. At least 50% of patients with sarcoid have fatigue. And that in some cases for my patients, they will find that there's some days they just simply have to have something to get through the day, or in other days they don't. I think fatigue has gotten a lot of play since COVID, and there's part of long COVID is fatigue. And so I think people are recognizing that this is something that can occur with chronic inflammation. I think it's important to discuss it with your doctor to realize that it's part of the sarcoidosis. It's not something that's made up in your mind. Often you gain weight with being on steroids, and your family friendly tells you that all you got to do is just go out and lose weight and you'll feel much better. That's not the whole story.
There is one more question in the chat box. How important are PET scans in sarcoidosis patients?
Again, I think the PET scan, which is an expensive test and has a high dose of radiation, so it is difficult sometimes to get it from place to place. We like to use them at our institution and most places now as a test to look for ongoing inflammation if we have to make a decision about whether to give more intense treatment or not. Sometimes, for example, in cardiac sarcoidosis, they're used as a measure to see whether you're responding to treatment. And if your PET scan is turning negative, whether you can go back. But for the most part, right now, we're using it to make a decision to go forward. If you cannot get a PET scan, you can still make the decision based on other things, such as quality of life, symptoms, and sometimes an empiric trial of treatment. I'd also point out a negative PET scan doesn't mean that you won't respond to more treatment. It's just one more guideline. I do see a question here about pulmonary function tests, sufficient to see how you are doing. And it points out that when they see their pulmonologist or consultant, that every time they see them, they do pulmonary function tests, and they've been doing this for 15 years. I think that this is one of the things that we try to emphasize is that PFTs are what we like as pulmonologists. That's something that we measure, and we do know that they have some importance in various diseases such as asthma and COPD. And in a disease called idiopathic pulmonary fibrosis, the drop in the pulmonary function tests are a very important prognosis. In sarcoid, the PFTs don't change that much, even with steroid therapy. When you're feeling much better, your PFTs don't change that much. So it's only one indicator. So if your PFTs are staying the same, but your x-ray is getting worse, you're having more cough, you're feeling bad, you should still think about other forms of treatment. I had a comment here about the lymph nodes in the mediastinum were so hard that they could not be biopsied. Would they ever soften again? Well, I don't know what they are seeing on the imaging, but for example, in my city, what happens is lymph nodes become what are called calcified. That is, as they scar up, they get calcium, so they become hard as a rock. And so this is part of the scarring when they become hard. Getting back to that skin example, it gets red and then it becomes just a scar piece. And that's not going to go away with our current therapy. So, but for the most part, the sarcoid lymph nodes just kind of are like soft pillows. They push things away, but they don't necessarily stop things. There is a rare condition called fibrosing mediastinitis, where those lymph nodes will press down on the the veins or the arteries or even the lymph glands on the drainage or the airway. But that's rare, and that's something that your doctor would follow along. But for the most part, the lymph nodes, once they become scarred, just sit there and don't necessarily cause problems. Stephanie had asked the question, is there a way to know whether my mild shortness of breath is due to my pulmonary sarcoid, my mild asthma, or not being fit? Well, this is usually the one of the questions that we get into. Again, this now gets into the quality of life question. Obviously, the difference between mild asthma and pulmonary sarcoidosis is therapy. Mild asthma, we think of drugs such as inhaled beta agonists to open up the airways for immediate, and things like inhaled steroids. As I mentioned, inhaled steroids may help with cough. They really don't help much with the shortness of breath in sarcoidosis. So if it's not responding to those treatments, you may want to think about treatment for the lung disease if your symptoms are enough to warrant therapy. Again, we're just trying to improve your quality of life. You say, well, yeah, I'm a bit short of breath when I go up 2 flights of stairs, but I can live with it. You can certainly exercise, and you can do things. You're not hurting yourself by trying to improve your exercise tolerance in that situation. If you have pulmonary sarcoidosis, doesn't mean you can't do things, and pulmonary rehab or even pulmonary exercises on your own can be helpful.
Professor Baughman, I think Janet wants to answer that question as well, or is that okay, Janet, for now? Something.
No, that's fine, Caroline. I was just selecting it for Bob to answer. Thank you.
I have another question here from Mark, the other side of the extreme, which is a patient. Mark has been diagnosed with pulmonary sarcoidosis, currently on the lung transplant list, which implies that he's got very severe lung disease. One of his questions is, well, what happens after the transplant? Does the sarcoid go away or not? I think you've probably been told, Mark, and we know that patients with sarcoidosis, once they get a new lung or a new liver, or whatever organ is transplanted, they will develop granulomas in that organ. For example, lung transplant, there's a 50-50 chance down the road they'll find granulomas in the new lung. However, that being said, it has not been a problem that over the time that the lung will be rejected because of the granulomas. And this is in part because the medication they give post-transplant, the thing to prevent rejection, are also very successful in controlling the sarcoidosis. They give steroids and they give drugs like mycophenolate. They can be quite effective in controlling the sarcoidosis. They give more than we would normally give for pulmonary sarcoidosis. So in point of fact, even though it can recur, it usually does not cause life-threatening damage down the road. I have a question about small airway disease versus pulmonary fibrosis. Small airway disease is a condition where on pulmonary function tests, as dreaded testing goes, that your total amount of air you're breathing out is fine, but as you breathe towards the end, you don't get the air out fast enough. And this is because the lung, you're breathing through a series of tubes, and at the end of that, the small tubes are the ones that determine how fast you get the air out. This is not the same thing as fibrosis. Fibrosis is where the lungs scar down. They just simply don't have as much air to work with. So in point of fact, the pulmonary function tests for fibrosis don't show any evidence of small airway disease for what it's worth. Small airway disease is something that pulmonologists will often look for in the person that, the example before, of somebody who has mild symptoms. Pulmonary function tests in general look okay, but they're short of breath. And they notice that their problem are that at that end, when they're pushing harder, which is what happens when you run up the flight of stairs, when you're trying to breathe deeper, you start having problems. That's a small airway disease. In some cases, treatment for that with asthma type symptoms can be helpful, but in sarcoidosis, which can cause small airway disease, those treatments just simply won't get there. And again, you're back to the same question. Do you want to treat it with something like what we call systemically, like prednisone or methotrexate, or whether you can live with the symptoms? There's a question about what is a pulmonologist versus a sarcoid specialist. In the last few years, we've been setting up centers of excellence across the world, and this WASOG and the ELF and other organizations have put together a list of what the WASOG, World Association of Sarcoid and Other Granuloma Disease, calls Center of Excellence. And what we've tried to do is identify not only pulmonologists, but other specialists who are interested in sarcoidosis, And that we want each of those centers of excellence to have someone who is specifically interested in sarcoidosis, because sarcoidosis is not a single organ disease. So a pulmonologist may be very interested in your lung disease and may be very interested in the problems with that. But we often will see in that situation, when you come to your pulmonologist and say, by the way, my eyes are now giving you a problem, and they'll say, well, that's not my problem because I'm just taking care of your lungs. So a sarcoid specialist would say, well, yes, we need to treat you for your lung disease and your eye disease and potentially your other symptoms. And we'll talk about systemic therapy. So that's where a sarcoid center of excellence, and the sarcoid specialist may end up being someone like a rheumatologist who's used to treating other forms of the disease, or an ophthalmologist or a neurologist, but we'll also defer to the pulmonologist to be sure that there isn't anything going on with the lungs. The lungs are affected 90% of the time, so that's why the lung specialist often is the start. One of the questions that comes up is, what is the latest hypothesis about the cause of sarcoidosis? Well, there are three major hypotheses out there. One is that the people at Vanderbilt and Johns Hopkins in the United States have very good evidence to suggest that there is a bacteria that's similar to what is seen with tuberculosis. It's what's called a mycobacteria, is seen in about 80% of their patients with sarcoidosis. The people in Japan, and then follow up with a study in China, showed that they found about 90% of their patients had evidence of exposure to the bacteria that causes acne, Propionibacter acne. And in the United States, there was also in 2001, the World Trade Center catastrophe, and the first responders to that, a group of them developed sarcoidosis directly related to their being first responders. I think of sarcoidosis as not a single stimulus, such as P. acne or this funny form of tuberculosis, but the inflammatory response to it. We all have had acne at some time or another, but not everybody gets sarcoidosis. And so I think it's the granulomatous reaction. And that's really what most of our therapy is based on, trying to treat the granulomas. We did do a large study called CLEAR, where we treated for this particular organism, the mycobacteria, a combination of 4 antibiotics for 6 months, for 2 months, and we found no benefit for just treating with the antibiotics alone. So we're still talking about treating the inflammation.
Yeah, there's a question on, centers of excellence in the state of California.
Yes, I think that this is good. And if I just only remember one, there is one at Stanford. There's good centers at both San Francisco and Los Angeles. I know that people in Loma Linda, for example, are interested in it. And so I think that where I would recommend, not only in the United States, but elsewhere, is to go to the WASOC site. The other one that has a list is the Foundation for Sarcoid Research of Centers. And there is a difference between centers and centers of excellence in our sites listing. So centers are just people who have expressed an interest in sarcoidosis, have somebody who is at center, who is particularly involved and has read a bit about sarcoidosis, but has not been vetted. The one that's become a center of excellence, and there are 49 of them across the United States, and Jeanette just gave you the link for that, are the ones that we have gone through a process of looking at what they have, what they offer. Do they, in particular, as I said, it's very important that the Center of Excellence have a wide base, not just focused on a single organ involvement of the disease, and identify people at their center or that they work with who help if you have a rare manifestation of disease, such as bone manifestation or kidney failure as a result of the sarcoidosis. So I think that's where the Center of Excellence. The Center of Excellence program was started by myself and Jan Gruders a few years ago with WASOC, and it's now being updated by Athol Wells and Dan Culver. But the Center of Excellence program right now is listed for you as for that thing.
Okay, are there any more questions? Please, we have a few more minutes left. Okay. Australia is sadly lacking. Yeah.
Marcus made the comment that Australia is sadly lacking, and this is an example. There are parts of the world that are not necessarily lacking in people who are knowledgeable about sarcoidosis, but have not necessarily been involved with WASOG. Just because they're not listed as a center of excellence doesn't mean that they're not interested in it. And I think I've been to Australia, talked about sarcoidosis there, and there are centers that have been doing work in that area. WASOG has been around since the 1980s. Originally, the society was put together in the 1960s, but obviously not everyone can join them. But we really encourage people to try to get out to reach people and to follow standard guidelines. The importance of the guidelines is to help people understand what we would recommend that be done. So even if you're, for example, a physician and your physician is not where the treatment centers, at least you can give them some guidelines. Sean asked a question about HLA typing. This is now something that does get very geographical. In the Scandinavian countries, there are very good evidence that HLA-D R003, DR002 is associated with a very good prognosis, meaning that if you have that particular genetic profile, your disease is likely to go away and never require any therapy. If you take that same genetic profile in the United States, it doesn't work. So HLA typing is still very specific to very small groups. And part of that is the genetic profile, and Scandinavia can be very homogeneous, so you can deal with the single gene. Sarcoid is a polygene problem, just like rheumatoid arthritis and cancer and other things. We hope in the future we have panels of genes that we look at to get prognosis, but we're not there yet. I'll talk about the African American get this disease. This disease is more common in African Americans in the United States, 3 times more common, but there are other genetic groups that are higher, but it's still commonly seen in all parts of the world. And in Europe, as I said, it's commonly seen, but it's more common in the Scandinavian countries, where it's about 3 times more common than elsewhere. But a fair number of people, for example, in France get this disease. So it's a disease that does have some increased risk in various parts of the world, but it's not a specific one group or another. There was a question about COVID causing a flare of symptoms, which are currently dominant. We did actually published several studies now on COVID and sarcoidosis. We did questionnaires when it first came out and such like that. It's probably like the flu. It will certainly make symptoms get worse, cough and stuff like that. And it can make your symptoms of the disease get worse. And it's really questionable what, for example, after COVID, if you got fatigue, is it because you had sarcoidosis or just another problem? What is clear, though, is that COVID was no more prominent in patients with sarcoidosis. That is, that you were not at higher risk, but you did, especially if you had bad lung disease, you did worse from your lung disease. It could make it flare much worse. We do recommend vaccination still, because we think that patients overall did well. And in our own clinic, that was the experience. We did have a very big second draft when the Omicron came through last winter. We had a marked rise in our COVID cases, but as opposed to the first wave, most of our patients were vaccinated, and with Paxlovid, we were able to avoid a hospitalization as we've seen in the first round.
Professor Baughman, there's a few questions and statements in the question and answer chat box, I think, just to double check.
I'll finish. I see Sarah's, and I may be just having a problem with scrolling. The comment about having 18 months of being on steroids and still feeling unwell and fatigued than I was when I was on steroids. There is this problem with steroid withdrawal making you feel tired, but my perception is that most of my patients, when they're that way, is that they still have active inflammation and that they need treatment, but not necessarily with prednisone. That would be drugs like methotrexate, and occasionally even infliximab. This would be an example of someone who I would think about doing a PET scan to see if you still have ongoing inflammation from the sarcoid. If you do, that would certainly be a reason to consider treatment. There's a question about cough. As we mentioned, Cough is a chronic symptom for sarcoidosis, and treatment really depends on how bad you feel about it. As the person with a low risk of diagnosis, again, there's a 10% chance of it coming back again. So I think that down the road, for the most part, the longer you go with the disease without giving you troubles, the more likely that you're not going to have the disease get active on you.
Okay. Okay, we're 5 minutes before 5 o'clock my time, Belgian time. If there are no more questions at the moment, we would like to thank Professor Baughman for his excellent explanation and answering all the questions. We would also like to thank all the ELF members and the people attending this webinar. If there are more questions popping up, you can always email ELF sarcoidosis on info@europeanlung.org. And so do remember, stay active, stay hopeful, talk to friends and peers, and enjoy life. Thank you very much for everybody attending.